Hi, Sam here. My campaign is set up around serving disenfranchised people. Specifically, in this instance, it's serving the homeless populations. We are currently in the middle of a pandemic that we've never seen before, and it's really shed a lot of painful light on what we're doing wrong and the fact that our populations, the populations that we serve as a collective whole, in homeless providership, um, we're not serving them very well, and we're not serving them in a way that's safe for us as providers. I personally feel like we should have been more prepared as providers because we do see influxes of disease and really hideous diseases like TB and hepatitis in our shelters. There's nothing new to these, but they are also something that I would consider pandemic um, possibilities. Um, this isn't the first time that I have considered what this looks like and how it presents in the population that I serve. Clearly, I am a homeless provider, and this is a nonprofit that I'm starting with medical providers. Um, I think that at this point, it's really important to open this narrative and open this conversation of what is it that we need to do differently. As such, our mission statement is to provide medical care and case management to underserved populations. This is a really, really broad mission statement, and the reason that it is as broad as it is because we don't plan on only serving the homeless population. We are planning on serving and expanding out to serve immigrant populations and um, refugee populations, non English speaking populations, because we've seen consistently that these are populations that hit huge barriers when it comes to access, uh, the ability to access medical care. Right now, though, the priority issue is providing medical care to disenfranchised people living in camps. Um, this is, again, kind of a broad statement, but we're seeing more and more camps um, disrupted in negative manners around COVID and this pandemic, which opens up a lot of conversation and dialogue in the public health field. Um, are we doing anyone any favors when we do this? We're seeing a lot of people who are stably housed who are blaming the continuation of this pandemic on the homeless population, which is not true. The homeless population didn't start the pandemic. Um, yes, they were seeing some people are getting sick, but the mass numbers of illnesses have been in stably housed people of higher SES communities, which opens an entire different conversation that needs to be had about how we, as a society, address those within our communities who are lower socioeconomic status because we're not doing a good job. We're seeing a lot of really not great people, or not even not great people. Maybe they're great people. People with not great dialogue and information. Um, as providers working with in the high risk arenas, it's well known that disenfranchised populations aren't getting adequate health care. Um, this is just reality. It's nonstop, and it doesn't start and end with a pandemic. It is absolutely and unequivocally what we are facing. We know as homeless providers and medical providers that it's just not there. We don't have the resources, or we don't have the people willing to put forth the resources without the income coming in. And we have a large homeless population in the U.S. This is something that is a huge barrier for youth, it's a huge barrier for adults. I know that MHCD is our primary mental health care provider for disenfranchised peoples, and it takes 6 to 8 weeks to get into MHCD. It takes 6 to 8 weeks to get in for an evaluation for mental health care anywhere in Colorado if you don't have private insurance, and then you're still looking at a pretty decent wait. Um, and of course, there are smaller clinics like Stout Street, which are they're fucking bomb. Um, Emerson. Like, these are great opportunities and options for our people, but they can't serve everyone all the time, right? And if there's already a barrier set up, I've seen this over and over again in the population that I serve. If there's a barrier to accessing medical care anywhere, it is a permanent, it's perceived as a permanent barrier. I'm no longer worthy of medical care because I'm homeless or because I can't afford it or because I have Medicaid. That is bullshit rhetoric. And it's what common society teaches people who are disenfranchised. You're no longer worthy. That's a huge piece of this, is that they are worthy. Like, it is absolutely, without a shadow of a doubt, a huge issue. It is a barrier. This is also a multifaceted issue. Medical providers don't have established relationships with people living in camps, partially because it's hard to get to the homeless populations, to consistently attend, get homeless people in the homeless population to consistently attend appointments. Part of that is, there's substance use, there's mental health care issues, transportation, money, work. These are all things that are acting as barriers. At the same time, the homeless population has a distrust in the medical community. There aren't enough case managers to create balance and facilitate relationships, and HIPAA laws often act as a barrier to creating said relationships. I see this all the time as a case manager in the homeless population, where I have clients who are like, oh, I need to do this or I need to do that, and I need you to help me get this letter or get that letter, or I don't have my ID. And I will absolutely and without a shadow of a doubt do my best to walk alongside my clients. But we see often that even in those walks, like, I can have an ROI, and the medical community would say it's still risk of breaking HIPAA. You're jumping through hoops as a case manager, and there's not enough case managers to be able to balance all the medical professionals and all of the populations that we serve to create harmony. Part of that is also that we see cycling through our medical providers. They don't want to consistently work in this population. That's a barrier for everyone, right? That's a barrier for me. It's a barrier for my clients. Or grants run out and there's no more money to pay them, to pay our medical professionals, and that is also a problem. That's a huge, again, that huge barrier piece. Because of these different barriers, because of these different pieces, it's really a priority issue in this campaign, to meld together case management and medical care to create an ease of access for the homeless community, because it's necessary, obviously. So with this, my campaign is set up with long-term, intermediate, and short-term goals, and kind of a trickle-down or a stacking, more of a stacking, hope and plan. Because if we don't have a good foundation, we're not going to be able to stack and achieve long-term success. The alliances that we currently have are with Urban Peak Denver, which is the organization that I professionally work with, the Colorado Coalition for the Homeless, Atheists for the Homeless, Metro Denver Homeless Initiative, so MDHI, which is a huge, huge space to have an alliance, Children's Hospital of Colorado, Denver Health, and various community outreach nursing programs across the U.S., Boy Scouts of America, Smart Wool, the Lab to Combat Human Trafficking, Volunteers of America, Johnson & Wales University, Metropolitan State University of Denver, Community Reach, as well as some various smaller organizations, so Impact Humanity, obviously AA, NA. These are all places that we have alliances already established, and a lot of that is us going out individually and doing work in those communities. Part of that is professional work, some of that is educational work, some of it is just outreach. opening up that conversation of like, yo, this is what we need. Like, we need help, and this is how we're going to reach our people, and this is how you can be part of that. So we've already started our campaign. I apologize, my narrative video is probably going to be longer than 10 minutes because our campaign is underway. It's been underway for a minute. So, and this class has like definitely added to that and will continue to add to it because I feel a whole lot more equipped. So we have 3 different targets, and we have different reasons for our varying targets. Target 1 is Elias Provencio Vasquez, which is the dean of the nursing school at CU. And the concept behind that is Kevin, my partner in this, he went to CU School of Nursing and has an established relationship with Vasquez. We want to create an independent study course for CU so that we can have student nurses come in and execute that medical connection piece, as well as learning case management. These are things that are really, really important for student nurses, things that are harder to learn in a classroom, easier to learn in person, and absolutely a necessity when it comes to having nurses who are interested in working in high-risk populations. The next person is Dr. Allegra Malelio. She is the head of the Urban Underserved track at CU. So her group of people at CU, her group of students, are all students who are going to school specifically to serve the underserved and urban populations. This is similar to a scholarship program at MSU, and that connection has already been made because I was part of that scholarship program and because I have connections within the Human Services Department at MSU. The concept there is that these are people who professionally and academically are already saying, like, I'm willing to commit to serving high-risk people. These are our people. These are the people we want to come align with us and work with us while they're going through their educational pieces, so they're better equipped as they go out into the population, as well as being prepared and having those established relationships within the communities. Our final group of targets, it's one target group, is the CDPHE, and that's Unified, so the Colorado Department of Public Health. And the reason that we want to do that is Kevin has some lofty ass goals of going into of becoming a senator. That is his ultimate goal, of going into politics. Because we very adamantly believe that we have to have a unified front for public health, and that legislation for serving the underserved and disenfranchised has to be in place. And we've seen over and over again, like, people are actively trying. We have different politicians actively putting up bills and like opening that dialogue of, hey, let's not have camping in Denver be illegal. Let's break down some of these walls and these barriers. Like, if you give someone who's disenfranchised food on the street, they can get arrested. But if you give me some food on the street, I'm not going to get arrested because I'm stably housed. That is a nonsense law. We need to start to change this legislation and redirect how our constituents, which are the people of Denver, the people of Colorado as a collective whole, how they look at that legislation. What does it mean? What happens when I tell you these things and you actually understand how severely us and them and delineating we are making this, when it's not an us or that and them situation. Everyone who is stably housed is a few choices and shit circumstances away from being homeless. And that's some real talk that people don't want to discuss. Um, so our team is currently built out of myself and Kevin, um, and very possibly a really cool chick named Krista, and um, that's that's it for right now. It's not going to stay that way. We need to build a team of us as the founders, a group of really amazing leaders, and a group of people who are just advocates and like bomb ass advocates who are willing to go out and be agitators and who are willing to go out and be ambassadors for us. So that is definitely, I'm gonna go with goal one for our short term goal is like we have to build up that team, because without that team, we're not going to be able to do as much. Uh, Kevin and I like to think we're superheroes, but the reality is we're superheroes who wear badges, and our capes get weary sometimes. Um, so that's that base building piece. So we need a great team of professionals that are aimed at serving and the underserved. It needs to be an ever expanding group because we're going to see barriers in access of service from our professionals when it comes to like licensing and cycling through medical school and cycling through like LPC and MSW programs and testing. So these are just the foreseen barriers to participation and service that we're seeing, like that we can look at. We also know like getting married and having kids. These are also barriers. Um, Maybe even grown up jobs, but whatever. I can fight that part. um, Obviously, I can't really fight that part, but I would like to. So these are the barriers that we foresee. So we need to create that base building and do it in a cyclical manner so that we can continue to have people who are coming through and working with us, and creating those establishments, or creating those and establishing those relationships. We also need to get support from nurse practitioners, medical doctors, LCSWs, crisis counselors, LPCs. And a big part of that is the legality piece. So for us to legally be able to serve these populations, we have to have an NP and an MD as the director of the medical directors of our organization. And we do have, again, that really bomb chick that I mentioned, Krista, is like, she's fantastic. She's an NP. She actually works at Denver Health, and she is currently acting as our medical director as we move forward. I met her when I was doing work for the Lab to Combat Human Trafficking. Cool chick. She's done a bunch of work all over the world with disenfranchised people and people in high-risk situations. She served in the Army for a long time doing that, and it was just amazing. Again, though, that piece has to be, we have to have a team of medical directors or a team of people who can step in as the medical director. Because everyone has different strong suits, and everyone's going to have their time to shine, to come up and to act in that place when someone else can't. This is hard work, and that's a conversation I have frequently with my teams at work, is the work that we do is thankless, and it's hard, and sometimes it's violent, and it's really, really emotionally exhausting work. I think that, or I find myself in a position as one of the founders of this, and as the more mental health centric provider in this, or founder in this, is that I need to worry about the well-being of the people that serve with me. I need to make sure that they are being taken care of and that they're taking care of themselves. And it's easy to get lost in this work. So that's base building. That's our short-term goal. We got to build that base. We need to, like, with that base, we can go out and start rocking out those midterm, intermediate goals. one of which is like going out and establishing relationships. I've already started doing that. Johnson and Wales has been a huge rock star piece in that because they donate prior to COVID. They were donating their baked goods once a week. So we would pack my car full and I would rock out in some homeless camps across the city and county of Denver, passing out food, talking about like medical needs, who needed to be seen, what needed to be seen, creating conversation around like safe needle use and providing those resources, which I mean, I didn't do anything monumental, but at least we had that conversation and um, people were accessing safe needle sites, so going and recycling their needles and they were accessing services and asking for help, um, and accessing Impact Humanity, which they have volunteer case managers for those people who didn't want to go to the coalition or be part of HYS, which is a big also barrier to access. For a lot of people who are experiencing homelessness, they don't want to be in the system, so they don't want to access shelter space. So our midterm goals, that's one of them. Curriculum development is a huge piece for that educational, or a huge factor in that educational piece. We are actively working on creating a full course semester to teach in nursing programs. This allows us a for-free staff of nurses in training to triage, while our MDs and NPs go out and do, and our RNs go out and do some of that bigger medical piece. And our case management human services workers come in and do that case management piece, establishing relationships and helping break down those barriers to access for like Stout Street and those continued alliances that we need to grow, as well as getting people into Denver Health, which is our #1 provider for the homeless population. Some of the tactics that we're using or hoping to use to achieve these midterm goals are, again, that base building. Without the base building, there's nothing. Creating temporary coalitions with larger organizations, i.e. Denver Health and Stout Street, that can help bring weight to our mission. Without those coalitions, CU is not going to let us in if we're not providing something bigger. And that part of that is coalitions between human services programs and nursing programs, as well as working interagency. That's going to be, I mean, those coalitions are big, they're important. So what we have currently is obvious, maybe obvious, hopefully obvious by this, is that we have some established relationships within Denver Health. We have some established relationships in Stout Street, and we have kind of like fingerling relationships there. So they're feeding in, and just strengthening that is so important. We have also some pretty great alliances with other groups and support with other groups across the U.S. That have done the same thing. So groups of nurses and case managers, so human service workers, who have created these courses and are teaching them in schools or having someone else teach the coursework, which is likely what we'll have to do since we, Kevin and I both work full-time in the community. So we need to provide cross-sectional education experiences for professional degree seekers. So that cross-sectional piece is, here's the classroom aspect, here's the real life aspect. This is what that looks like as providers, so like the medical piece as well as the human services piece, because they are really, really important when working with marginalized populations. If you don't have both pieces in place, you're going to lose a lot of trust, and people won't access through you. So that leads to our long-term goal, which Sorry, I missed something in my short term or my midterm goal, which is um, creating information, consumable information for our ambassadors and agitators, um, because we want them to be able to disseminate that information to the public, um, so that we can teach, obviously, other people, as well as secure funding from corporations and help with that base building piece. So our long-term goal is to provide ongoing triage and medical education to underserved populations, because we don't have an existent strategy and we have a broken system. The short term and the midterm goal really feed into both of those things, or into that. And we have to be able to integrate everything together for it to be able to function and work right. So yeah, that's where we're at. Thanks.